So hello everyone, let's begin with the next module. The next module is on tuberculosis. Tuberculosis. So tuberculosis, let me tell you, in the whole of the medicine modules, this is one topic that you should know in and out A to Z. Okay, such an important topic, not just from the point of view of your entrance exams, but again, as a health problem, this is one disease all health professionals should know in detail. When I mean all health professionals, maybe someone who's finished his MBBS and is doing a general practice, or maybe somebody who has finished MD medicine and is practicing, or somebody who's a infectious disease super specialist, or maybe even surgeons, orthopedicians, obstetricians. See, whatever stream you are in, I think this disease being such an important global burden, okay, not just in our country but in the global scenario as well. It is a health burden, it's a social burden. So this is one disease we should know in and out. Okay, so this tuberculosis, as you all know, is caused by the organism that is Mycobacterium tuberculosis. Mycobacterium tuberculosis. Just a few properties of this organism. This is an obligate aerobe. Okay, the organism is a obligate aerobe, and this is a weak gram-positive bacillus. Okay, and this is a rod-shaped bacillus. This is a rod-shaped bacillus, and this bacillus contains mycolic acid in its cell wall. Okay, this contains mycolic acid in its cell wall, because of which it is acid fast. Okay, because of which it is acid fast. So these are some basic points that you should know about the organism. So let's meet our villain here. Okay, he is our villain. Okay, this is nothing but a Ziehl-Neelsen staining, okay, of Mycobacterium tuberculosis, which is acid fast, and you are able to appreciate these rod-shaped structures throughout. Yes, are you able to appreciate? So these tiny bacillus, okay, the Mycobacterium tuberculosis is causing such an impact in the health scenario. Okay, all right. So having understood and having met our organism, let's try to go and explore into the disease. See, tuberculosis, to begin with, I think we should have an idea of the global health impact of tuberculosis. That is very, very important. And we'll have a comparison with the Indian scenario as well. So see, this tuberculosis, you cannot say that we are celebrating the tuberculosis day, but we are observing the World TB Day on March 24. Okay, March 24. So why is this March 24 so peculiar? Because it was on March 24, 1882 that who discovered Mycobacterium tuberculosis? Robert Koch. Okay, so that your Robert Koch described or he discovered the tubercle bacillus. Okay, so because of that, March 24 is going to be the World TB Day. Now, next I'm going to show you a picture, which was released associated with the World TB Day of 2021, that is March 24. So you see here the World TB Day, okay, 2021. So the slogan of this World TB Day 2021 is "The clock is ticking." Okay. So any guesses on why this particular title, "The clock is ticking"? So see, in this description, or in the description of the slogan, they have said like this, that see, it is time that the countries where the incidence and prevalence of tuberculosis is high, the concerned authorities take it more seriously and implement measures so as to contain tuberculosis. Okay, so which is why it is said that the clock is ticking and it's high time that we contain the infection. Okay, and if you see the bottom part of this picture, they have given certain stats. Okay, the stats are, I just want to discuss that with you as well, just to tell you and justify my statement that this is such a important topic and all health professionals should know it. You see here, ever since 2000, it is 63 million, that is the lives saved since 2000 by the global efforts to end tuberculosis. And in 2019 alone, you had 10 million people who fell ill with tuberculosis, and 1.4 million died with tuberculosis in 2019, and 4,65,000 people fell ill with drug resistant tuberculosis. So, that again is a major challenge, the drug resistant tuberculosis. So, you had 4,65,000 who contracted drug resistant TB in 2019. So I'm sure that you would have seen these large numbers and you might have understood, okay, this is the global impact. Now let's have a comparison with our country. So these are the estimates of tuberculosis burden. Now this comparison is with respect to the 2018 data, because we had the survey was done in our country in 2018. So let's actually make a comparison with the data. You see here, it is given the incidence of TB cases, mortality of tuberculosis, incidence of HIV TB, mortality of HIV TB, MDR TB, and about children affected with TB. You see here, in India, 2.69 million, okay, incidence of TB cases, 27% of the global incidence. 27% of global incidence. And when it comes to mortality, again 31% of the global mortality. The incidence of HIV TB comparison to the world, it is 9%, and mortality of HIV TB is 4%. We will see in due course how this HIV TB, this deadly combination, again produces or creates such a havoc on again the health system, because again it is very difficult to treat. And MDR TB, India is contributing 24% of the MDR TB cases. And what about children with tuberculosis? 31%. Okay, so the numbers are big in Indian stats as well as the global stats. So that underlines the importance of this disease as a global health problem. Now, when we are going to see this disease in proper, okay, the disease as such, my discussion will be such a way that initially I will be going to the etiopathogenesis of tuberculosis, how this disease is contracted, and what happens when Mycobacterium tuberculosis, the bacilli, our villain, enters our body, what happens, the sequence of events that happens, and what is our body's response, and what are the differences between immunocompetent individuals and immunocompromised individuals in containing the infection. Subsequently, I'll discuss the clinical features, and then I'll come to the diagnosis of tuberculosis, the various strategies that we have, and then regarding the treatment. Okay, this is the outline in which I'll discuss this topic. So before going into that, let me just tell you one more thing. I'm sure you would have heard of this term, RNTCP, that is your revised National Tuberculosis Control Program. Revised National Tuberculosis Control Program. So this particular program, the RNTCP, in fact all the guidelines of tuberculosis in our country comes in the RNTCP brand. But the RNTCP title, it was changed in Jan 2020. So currently we do not have the RNTCP. What is there is the NTEP. Okay, NTEP is the current terminology. That is your National tuberculosis elimination program. See, you might have observed when you learn all your health programs in your PSM, they have a habit of changing the names periodically to make things tougher for us. So yes, this term RNTCP does not exist now. Now you have the NTEP. It was because why this name was changed is because the government had certain policy changes. It decided to be a bit more aggressive in containing the tuberculosis infection. So rather than a control program, they wanted elimination. So because of that, they changed the name to NTEP. Okay. All right. So along with the name changes, what are the other policy changes with respect to diagnosis and treatment? We'll see that later. But I just wanted to introduce it to you. And let's move on to the disease proper. So how is this disease spread from one person to another? So Mycobacterium tuberculosis, the spreading of this organism is again, the transmission is an airborne transmission. It is an airborne transmission. Airborne transmission, that is by means of the droplets. Okay. So what happens is that you can see this is an individual who is a active case of tuberculosis. You can see he's already having some cavity. So all these mycobacterial load in his cavity, through the airways it comes out as droplets, and by these droplets it goes to the nasal cavity, and subsequently it is inhaled by this other individual. So that is how he is exposed to the tubercle bacillus. Now in the course of the discussion, let me tell you, TB infection and TB disease are entirely different. Because in our country where tuberculosis is such a common problem, there is a good percentage of individuals who are already infected with tuberculosis. They may not manifest the disease, probably because they have already contained the infection by means of their body's immune response. Okay. So disease is when you manifest the disease, when either your immunity is low, or maybe the organism has there is a lot of a bacterial load and it has produced a devastating disease manifestations in an individual. Okay. So TB infection and TB disease. So I told you how it is transmitted, droplet nuclei. Now what we are going to see is, suppose there has been in this particular individual, in whom you have had the inhalation, let's call him Mr. X. Okay, so Mr. X has inhaled this tubercle bacilli. So what is going to happen after this? That is what we are going to learn. So let's see two scenarios. One in which Mr. X is immunocompetent, and number two is when he is immunocompromised. So the first scenario is when he is immunocompetent. See, when he is immunocompetent means he is having adequate immunity, so the chance of a containment of infection is more. Always know that when you contract a bacillus, okay, a Mycobacterium tuberculosis bacillus, the major line of defense against this bacillus is going to be your alveolar macrophages, your pulmonary alveolar macrophages. Okay, pulmonary alveolar macrophages. So let's see if your Mr. X is having a good immunity, how is he going to deal with this infection? You see here you have the alveolar macrophages, and here is the Mycobacterium tuberculosis antigen. So what this alveolar macrophages will do is that they will first present this antigen to your T cells. So you can see here you have the T cells, and your alveolar macrophages is presenting the antigen to the T cells. So when a antigen is being presented to the T cells, what will naturally happen is going to be your activation of T cells. So your cell mediated immunity is very important here, and it is when the T cells are activated, especially it is the Th1 subtype that becomes activated, T helper cell 1 subtype. So when the Th1 subtype gets activated, it results in the release of cytokines like interferon gamma. So when you have release of various cytokines, it results in the activation of macrophages. Okay, so your macrophage has now become very active. Mr. X's macrophage has become very active, and this macrophage will destroy or kill your tubercle bacillus. Now, how does it kill the tubercle bacillus? That is, it can be by phagolysosomal activation and maturation, production of either nitric oxide or reactive oxygen species, or by autophagy. That is how it will mediate the mycobacterial killing. Okay, so he has got a very good immune system. And not just that, it will release certain cytokines which will recruit the inflammatory cells. Okay, see, whenever you want help, okay, suppose you have somebody's coming and trying to hit you, first you will punch the person back and then you will call others for help. So similarly, the macrophages will call others for help. That is, the other inflammatory cells, the monocytes will be recruited. So you will have the epithelioid cells coming in. So all in all, it will result in the formation of the granuloma. Okay, I'm sure you might have learned in your pathology lessons that in fact this picture itself is from Robbins. So it results in the formation of a granuloma so as to contain the infection. Okay, it forms a granuloma so as to contain the infection. And yes, at the central part of the granuloma, you might also have some caseous necrosis happening. Okay, so that is how the infection is being contained. See, the credit should be given to a good immune system. Correct. So Mr. X had a good immune system which helped him in containing the tubercle bacillus infection. Okay, so next is a scenario where suppose if Mr. X did not have a good immune response. Okay, suppose he had his cell-mediated immunity is not that great. So maybe he is a patient with diabetes, or maybe he is having a retro infection, or he is having malnutrition, or maybe he is a alcoholic, or maybe he is having some other chronic illnesses like chronic kidney disease, or maybe he is having some illnesses for which he is on steroids like SLE. So if there are some contributory factors that has made Mr. X a bit immunocompromised, there is a chance that his cell-mediated immunity is not that great. So in such a scenario, you remember the major line of defense, your alveolar macrophages, they will not be able to contain the infection. Okay, so why it is not able to contain the infection? See, the problem is, the phagolysosome formation, which is very important to contain the infection and kill the tubercle bacillus, that is not happening. So because of some mechanism, the Mycobacterium tubercle is not being killed by the phagolysosome formation, and because of which inside the macrophage itself, you will have proliferation of the bacilli. See the irony here, the macrophage is the major cell that is your line of defense against the bacteria. So here the bacteria is proliferating inside the macrophages just because it is not able to form the phagolysosome and kill the tubercle bacillus. So subsequently you will have lots of bacilli inside the macrophage, and subsequently it will be released to the bloodstream as well. There can be seeding of other organs, and you can have a disseminated picture as well. Okay, if it goes to seeds to other organs. But all in all, again, let me reiterate one point. Tuberculosis disease is again not just a simple disease that is caused by Mycobacterium tuberculosis. So this is one disease where the agent factors, the host factors, and your environmental factors are important, because not everyone who contracts the bacillus is going to develop the disease. So it depends whether if your immune status is good, if you are adequately nourished, if your socioeconomic status is decent. Okay, socioeconomic status is decent means it again is indirectly reflecting the nutrition status. So in such a scenario, you will be able to contain the infection. So just don't think that it is not a disease where you can just say Mycobacterium tuberculosis causes tuberculosis. It's way beyond that, because all these factors are very important in the causation of tuberculosis. All right. Now, having understood the basic, the pathology that happens, next I'm going to tell you the timeline of events, or maybe the time course of events that happens once a tubercle bacilli enters your Mr. X. Okay. See, the bacilli has reached the lungs of Mr. X. What is going to happen? That is what I'm going to tell you. So this is your lungs of your Mr. X. Okay. And first what happens is that this bacilli that is inhaled, it will go and form a focus, and that particular focus is known as the gone focus. Okay, so it is nothing but a bacillary foci, and this focus is usually formed in the lower part of the upper lobe, or maybe the upper part of the middle lobe. Okay, or you can say if it is your in the right lung, you can say the middle lobe, otherwise you can say the lower lobe. So whatever it be, it is almost in the mid zones that you have the initial foci of the gone focus. Now when there is such a focus, gone focus, the lymphatics also draining that particular area would be involved. There will be some sort of a lymphangitis, and subsequently the drainage of that particular focus will be to lymph nodes. Lymph nodes in the hilar region as well as your paratracheal region. So those lymph nodes also would be enlarged. Okay. So along with the gone focus, okay, the gone focus, you may have lymphadenopathy. And where is the lymphadenopathy? Lymphadenopathy is a hilar as well as a paratracheal lymphadenopathy. So such a gone focus plus this enlarged lymph nodes is what you will call the gone complex. Okay, gone complex. So you understood what is a gone focus and you understood what is a gone complex. Correct? Now what happens is, if your Mr. X is able to mount an immune response, he will be able to contain this infection. So both the gone focus as well as the lymph nodes, they will undergo healing. You will have a healed and probably calcified gone focus plus a calcified lymph node enlargement, lymph node. So such a healed or a calcified gone focus plus the calcified lymph node is what you call the Ranke complex. So that is when your body has been able to contain the infection. Now let me take you to a picture in Robin's textbook, if you are familiar with this. You see here there is a primary infection. The bacilli has entered Mr. X's lung, and it has gone to the lung, and in the lung it has formed the gone focus. So this is your gone focus. Just one more point about gone focus. See, the location of gone focus, okay, the location of gone focus is usually subpleural, okay, just beneath the pleura. Okay, it is subpleural. So beneath the pleura you might have a focus, that is your gone focus, and you see here there is some enlargement and caseation in the lymph node as well. So that is what is your gone complex. Okay, so this is what is your gone complex, and this is what happens in something that is known as your primary tuberculosis. So what is your primary tuberculosis? It is nothing but your bacilli entering the lungs in an individual who is not been previously exposed to tuberculosis. So in a naive individual, you are having a tuberculous infection, and the end result is what is your primary TB. So primary TB, actually what is going to be formed? The Gons complex is going to be formed. And when a Gons complex is formed, the question is, will the patient be symptomatic? See, the patient can be asymptomatic. The patient can be asymptomatic, but may also have symptoms like fever, maybe a bit of pleuritis, because this is subpleural in location. So a bit of pleuritis may be there. You may also have at that particular point of time erythema nodosum, or maybe a flictenular conjunctivitis. So these are the probable manifestations of what? Your primary TB. So primary TB is related to what formation? Gons complex formation. Now when an individual develops primary TB, okay, what happens next? Does the disease progress, or does he contain the infection, or does it go to a latent stage? That is what we are going to see next. You see, this is the primary complex that has been formed. And once the primary complex has been formed, there are different ways in which the infection can proceed. Most commonly, the lesion would heal. Okay, the lesion would heal. You will have the formation of the Ranke complex. So you will have a scar in the region of the Gons focus, and probably a scarred and a calcified lymph node as well. So that is one way if your immune status is good. So in such an individual, after the initial maybe an asymptomatic stage, or maybe the fever and the pleuritis, after that the patient may be completely asymptomatic. And sometimes when an X-ray is taken for some reason, you might see these two. You are seeing the white arrow, that is the calcified hilar lymph node, and this is the subpleurally located Gons focus which has calcified, and now you can say this is the Ranke complex. Okay, so this X-ray was taken for some reason later, and then you find this, and okay, so this person has probably had a primary tuberculosis in the past. Okay, so that is one sequelae. So this primary tuberculosis most commonly will go for healing. Okay, but in addition to that, you can also have other fates. Okay, let's see what are the other fates of your primary tuberculosis infection. So one fate is that an individual can go for a progressive primary tuberculosis. Progressive primary tuberculosis. Now what is this progressive primary tuberculosis? Progressive primary tuberculosis. See, progressive primary tuberculosis means, you see in the picture here, the body was somehow not able to mount an immune response and contain the Gons complex, because of which, the disease has progressed. Now when the disease progresses, okay, you can see this is a progressive primary tuberculosis. Now when the disease progresses, what happens is that the individual may have certain features. Yes, he may have a fever. Okay, he may also have other features. He may have a pneumonia that develops, that is a tuberculous pneumonia that develops. So remember, this occurs all in individuals who have a compromised cell-mediated immunity. This usually occurs in this progressive primary tuberculosis, usually occurs in the children, okay, commonly. So you might have a fever, you might have a pneumonia, and sometimes what happens is that the lymph node can get enlarged. So there is an enlarged hilar lymph node. So this enlarged lymph node, what it can do is that probably this lymph node can cause an obstruction of some airway, So it can cause an airway obstruction, which may be either a partial obstruction or a complete obstruction. So when there is a partial obstruction, what happens is that it almost creates a ball valve like mechanism. So when it creates a ball valve like mechanism, what happens is that the air goes inside the airway but does not come out. So there occurs some sort of a hyperinflation. Okay, that particular airway, there is a hyperinflation happening. Sometimes the airway obstruction may be complete, because of which you might have a atelectasis or a segmental collapse may be there. Okay, the segmental collapse. And sometimes you might also have a cavitation that develops, correct? A cavitation that develops, and sometimes you may have a pleural effusion that develops in case of a progressive primary tuberculosis. So it's a progressive primary infection that occurs, and these are the manifestations that can occur. Okay, so just a pictorial representation of your progressive primary tuberculosis. Okay, this is a progressive primary TB. You can see cavitation developing. You can see some sort of an effusion. You can see the lymph nodes. So these are the manifestations of a progressive primary tuberculosis. So that is another fate of your tuberculosis infection, progressive primary tuberculosis. Now some individuals, if the immunity is significantly compromised, from this primary TB which has progressed, you may also have a miliary TB developing. There is a hematogenous dissemination happening and multiple organs are involved. You will get a progressive primary tuberculosis. Okay, so that is one fate of your tuberculosis infection. So either it may be a healed lesion, or it may be a primary progressive tuberculosis, which again becomes maybe disseminated as well. Now this is fate number 1, this is fate number 2, there is a fate number 3 also. That is, the organism you can go on to develop a latent tuberculosis infection. Latent tuberculosis infection. So which means this organism will remain, okay, so that is a LTBI, latent tubercle bacilli infection. The organism would remain latent or dormant in the region where it has caused the Ghon's focus. So probably the immune system has not been able to contain it, and it remains dormant, waiting for its chance. It remains dormant. Okay. Now these are very important. Okay, these are the main states or the fates of your tuberculosis infection. Now what happens is, see, suppose somebody has developed a latent tuberculosis infection. Okay, so the organism is there dormant, and for a long period he is not having any symptoms. But sometimes, suppose he has been exposed to a new, say, an environment. Environment means, suppose he is currently his nutrition status is compromised, or maybe he has developed some chronic kidney disease or a disease where he is on steroids. For some reason, his immunity status is compromised. That is when you have a reactivation. So an individual can develop a reactivation subsequently, resulting in post-primary TB, okay, which is also referred to as your secondary tuberculosis. Post-primary TB or secondary TB, it's nothing but a TB reactivation. Tuberculosis reactivation. That is your secondary tuberculosis. Now, when such a reactivation occurs, reactivation of this infection occurs, now that is when it is your upper lobes, predominantly your the apical and posterior segments of upper lobe, that is the one that is going to be involved in a secondary tuberculosis or a post-primary tuberculosis. Now, I am sure that you know the reason why this infection predominantly occurs in the upper part of the lungs, because you might have learned this in your physiology lessons as well. Because when you take into account the V by Q ratio, ventilation perfusion ratio, the V by Q ratio is highest at the apex of the lungs. Okay, highest at the apex of the lungs. And because you have a high V by Q ratio at the lung apex, the bacilli is likely to produce a secondary reactivation or a secondary TB in the lung apex. So the lung apex is the favored site, okay, of a secondary TB, very important. And also what happens is that the secondary, when the reactivation happens, it might result in cavitation. Okay, so the foci, it starts as a foci and subsequently it is converted to a cavity. There is a cavity that is developing, and when this cavity is communicating to a bronchus, what will happen? Because the cavity you have here will be studded with the tubercle bacilli. It will be studded with the tubercle bacilli, and when it communicates with an airway, the bacilli comes out in through the droplets of this particular individual. Okay, so what will be the symptom when a patient develops a secondary TB? Yes, you can have fever, you can have cough, and yes, the cough is likely to be productive. You can have either a mucoid sputum, mucopurulent, or maybe even a purulent sputum. So fever will be there, cough will be there. But remember, this is a systemic illness, and the patient so will be having loss of appetite, loss of weight. Okay, he will be having loss of appetite, loss of weight, and it's like the patient would sometimes, initial stages, sometimes even before developing any symptom, maybe even before the cough also, he might see that his weight is coming down. Okay, so that is when he might be thinking, what is wrong. So you will have a loss of weight as well as loss of appetite, and subsequently if this cavity erodes into some blood vessel, because adjacent to the cavity that you have here, you might have some blood vessels. So especially you will have your bronchial vessels that are going to be your eroded, and subsequently you may have hemoptysis, and in some instances you can have even massive hemoptysis developing. And so not just the bronchial artery, because bronchial artery is more likely to be involved as the supportive connective tissue is less for your bronchial artery. So you can have hemoptysis, but your pulmonary artery may also be involved. And when the pulmonary artery is involved, it results in a pseudoaneurysm, and this pulmonary artery aneurysm that develops adjacent to a cavity of a secondary tuberculosis, that is what you call the Rasmussen aneurysm. Okay, that is what you call your Rasmussen aneurysm. Okay, so fever, cough, loss of appetite, loss of weight, hemoptysis. One point is like, again, night sweats. Though it is not very specific for tuberculosis, in our country many individuals have these symptoms of night sweats associated with the tuberculosis. And other than these manifestations, sometimes what can happen is that the bacilli can get disseminated. So in such a scenario, you can develop a disseminated tuberculosis as well, disseminated TB. And when this dissemination occurs through the hematogenous route, you can have involvement of your other organs, but at the same time, suppose if an individual, the right lung apex was involved, see, the infection can get into the opposite lung as well. So you can have a bilateral involvement as well. It is not that the lung involvement tends to remain unilateral. It can have a bilateral involvement. The organism can seed into the other lung as well. Okay, so that is also very important. So you can develop a disseminated tuberculosis also. So this is how an individual would manifest with a secondary tuberculosis. And when you examine the individual, he may have clubbing. Obviously, he may be emaciated. Maybe there is loss of weight, loss of appetite. Sometimes, he might be malnourished, just because that the malnourishment might itself be the triggering factor for the reactivation of tuberculosis. So there will be clubbing, and again you will have auscultatory findings as well, because you have got a cavity there. So you might have on auscultation maybe a amphoric breathing over the cavity. And also you might have another auscultatory finding, that is your post tussive suction. That is because when you cough, what happens is that the cavity initially might collapse, but then when the air gushes in, the cavity again expands, so there is a suction sound. So after this cough, when the air is sucked in, there will be a suction sound that is produced, that is your post tussive suction. Okay, it is usually seen when the cavity is thin-walled and more collapsible. And you might have other features, like you might have if it is a disseminated involvement, you can have a splenomegaly. Even auscultation, you might have crepitations also. So these are the important examination findings in case of a secondary tuberculosis. Okay, so that is it about the manifestations, or how a primary tuberculosis infection would have the various fates, and might have a secondary TB. You see here the secondary TB. There may be a cavity, caseation, scar, and it goes to the other lung as well, caseation. And then again you can have a massive hematogenous dissemination and resulting in a miliary TB. A simple but very important diagram from Robbins, which summarizes the whole pathogenesis of pulmonary tuberculosis. Now, in addition to these areas, you can also have extra pulmonary TB. See, in addition to your pulmonary TB, you may also have extra pulmonary TB. So extra pulmonary TB means organs other than your lungs are involved. So it can involve various sites, but the most important one, you can have your lymph node. So lymphadenopathy, especially your cervical lymphadenopathy, is the commonest extrapulmonary manifestation of tuberculosis. You can have a pleura involvement resulting in a pleural effusion. You can have genitourinary tract involvement as well. Okay, so again, these are the common sites of extrapulmonary tuberculosis. You can have your skin also being affected. So lots of extrapulmonary sites are there for tuberculosis. Okay, so extrapulmonary tuberculosis is also very important to diagnose, because sometimes the only presentation of the patient may be a asymptomatic lymphadenopathy. But when you actually ask the history of the patient might report some weight loss. So this is very important, because sometimes a lymphadenopathy can go to a surgeon or maybe a general practitioner. So whatever it be, sometimes if you just consider it to be any other infection, you might just treat with a course of antibiotics. But if you do not follow up the patient well, then he is likely to progress. Okay, so early diagnosis is very important in case of tuberculosis, let me tell you. So though this is a slowly progressive infection in many patients, but if you do not recognize at the right time, he can go on to develop a disseminated tuberculosis. Or maybe even if it is restricted to a particular organ, the bacillary load might increase and sometimes it might be difficult to treat. And there is a chance that he might actually especially if it is a pulmonary tuberculosis, he might be a source of infection to the community as well. Okay, so just let's look a few x-rays here. This is a secondary tuberculosis. He has developed a cavity. So you can say it's an active case of tuberculosis. Why do I say it's an active case of tuberculosis? Is because this cavity will be having a lot of bacilli, and he would be, when he is actually coughing, by the droplets, there is a chance that others can get the infection. And this is a classical miliary tuberculosis where the dissemination has happened. So it is like millet seeds. Okay, this is a miliary TB, just like your millet seeds throughout the lungs. And in such individuals, when you do the fundus examination, you are likely to see choroidal tubercles. You might have learned this in your ophthalmology as well. You might see choroidal tubercles. So that's your miliary tuberculosis. So I think we have seen in detail regarding the clinical manifestations and the disease course of the pulmonary tuberculosis. Now, having understood the pulmonary tuberculosis in detail, the clinical features, let's try to discuss the diagnosis. Now, just let me tell you another thing, that along with the clinical features, it won't be right if I do not mention that if an individual has a HIV TB co-infection, let me tell you, it is again a deadly combination. Okay, it is a devastating complication, because that is when your tubercle bacilli is more difficult to handle, because these two are good friends. Okay, so in fact, for you they are enemies. So the organism, when it occurs a co-infection, remember you have two chronic illnesses which are bringing down your immune status. So especially if it is an HIV infection with a very low CD4 count, there will be also a chance of development of other opportunistic infections. Okay, which is why we say if you have a patient with tuberculosis, always you should screen for HIV and vice versa also. Very important. Now coming to the diagnosis part. Again, diagnosis part I would say is important, because you might get questions from the general medicine part, as well as maybe a bit of a microbiology integrated questions also can come. So this is very important. Now when it comes to diagnosis of tuberculosis, first and foremost, I think the discussion should start with your sputum smear microscopy. Sputum smear microscopy. So sputum examination is very important. So sputum, when you try to obtain sputum from an organism, from an individual, and you try to demonstrate the acid-fast bacilli, you can do it by the Seal-Nielsen staining. Okay, you have the Seal-Nielsen staining, and you look these organisms under the oil immersion microscope. Seal-Nielsen staining and oil immersion microscopy. And see, when you look for these organisms, when you want to obtain sputum, for certain individuals, you will definitely obtain sputum very easily. Okay, they are having some cough, productive cough. So when you want to obtain sputum, you've got to take two samples. Okay, you've got to take two samples. That is as per your, currently it is not the RNTCP. I told you it is your NTEP. You have got to take two samples. Now, what are the two samples? One sample is going to be a early morning sample, and the second sample is going to be a spot sample. So, you are going to have an early morning sample as well as a spot sample. Early morning sample, spot sample. Now, two samples have to be taken. So, ideally, you would prefer a sputum amount of around 5 ml. That is ideally preferred. Now, if any of these samples turn positive for the bacilli, you would say that the test is a positive. It need not be that both samples should be positive. Any of them should be positive. Now, when you collect bacillus, and I'll just show you. This is just a representation of your collecting your sputum sample for testing for tubercle bacillus. Always the person who is collecting the healthcare provider who is there, he should be sitting by the side only. Okay, where it is not like the person is coughing and you are sitting right in front of the patient. No, he has to be at the side only, as you can see in the picture, and he has got to take 2 to 3 respirations, and then he has got to cough and into this tube, and then he has to close it. Okay, so one way is that you can collect it from himself. You will definitely get the sputum sample, but in certain individuals you might not be able to, the person might not be having cough. So in that case, you will have to go for a inducible sputum sample, by which I mean you will have to maybe give the patient a nebulization with a hypertonic saline. So when there is a nebulization with hypertonic saline, you might be able to get the sputum. So that will be obtained, and it is always nice that you mention that it is an inducible sputum, because see, when you induce sputum in somebody, this might sometimes look like saliva. So the person who is actually the healthcare provider who receives a sample might sometimes be confused that whether this is saliva. So if it is an inducible sputum sample, it is always better that you mention in the requisition form that this is an inducible sputum sample. Now in some individuals, if the sputum sample is difficult to obtain, you can even go for a bronchoscopy and a bronchoalveolar lavage, or you can go for a gastric aspirate. Now this might be required in case of children especially. Okay, so sometimes you will have to go for a bronchoscopy and you do the bronchoalveolar lavage and collect the sample, or in case of children, you can go for gastric lavage as well. So that is how you will collect this specimen sample. Okay, now this is just a demonstration of the acid fast staining, your Seal-Nielsen method in oil immersion microscopy. You can see the bacillary load is so much. Okay, so you'll have lots of TB bacillus here. Now just a few points, when you want to, suppose you have tested the sputum, and there should always be a grading. So the grading of this sputum sample based on the bacillary load, see, it is based on the number of bacilli that you get per immersion field. Now when there are more than 10 AFB per oil immersion field, and remember, you have got to examine at least 20 field. So you cannot be a lazy person, you cannot just be contented with one field. You have got to check a minimum of 20 fields, and if you have more than 10 AFB per oil immersion field, you put it as 3+. If it is 1 to 10 AFB per oil immersion field with a minimum of 50 fields examined, it is 2+. If you have 10 to 99 AFB not per immersion field, per 100 oil immersion field. Do not get confused here. This is per 100 oil immersion fields. When you examine the minimum of 100 fields, and then you give 1+. And if you have 1 to 9 AFB per 100 oil immersion field, when you examine 100 fields, you can report it as scanty. Remember, scanty does not mean he is negative. Scanty is also positive. So all these are positive. Scanty, 1+, 2+, 3+, all these are positive. Now when do you say the test is negative, your sputum spear microscopy is negative? You say when there is no AFB in 100 oil immersion fields, that is when you say this is negative. Clear? Very clear. All right. So you have understood that. Now in addition to your oil immersion microscopy and your Seal-Nielsen oil immersion microscopy, you can also go for the fluorescent AFB staining. However, it is in a resource limited setting, you do not have much facilities, but you can also go for the fluorescent staining where you do not have to use a oil immersion microscopy, and the advantages is that rather than a Seal-Nielsen method, it allows for a faster screening and is a bit more sensitive as well. Okay, it is more sensitive. Again, it is recommended by the CDEC as well. So you can go for a fluorescent AFB stain. Okay. All right. So that is it about the sputum smear microscopy. So you are very clear about the sputum smear microscopy. So after the sputum smear microscopy, second investigation modality that you are having is your culture. Now, traditional culture media are available like your Lowenstein-Jensen medium, okay, and you have other mediums as well. You have your Middlebrooks medium. So you have various traditional culture methods, but the problem with this LJ medium especially is that it would take time, almost up to 6 to 8 weeks. So suppose you give your sputum sample and waiting for 6 to 8 weeks, is not that advised. Middlebrooks is slightly more faster, but again the conventional culture medium, the problem is the time that it takes for a result to come. Okay, so that is a problem. So because of which currently we are advocating more the automated culture methods. Automated culture methods. So that can be used. Now, what do I mean by automated culture methods? You have mainly two automated culture methods. I'll just show you. One is your BACTEC 460 method, which is actually a radiometric method. Okay, so this is a radiometric method. So in which you might require a radio labeled carbon. So it is a radiometric method. So the problem will be the disposal of the radioactive waste. But this advantage is that you get results quickly. You do not have to have such a long waiting period. So one method is your BACTEC 460 method, and second method is your BACTEC MGIT 960 method. This is another automated culture method. So MGIT stands for Mycobacterial Growth Indicator Tubes. So this culture system also you would get the results quickly. Okay, so that is again a big advantage of your automated culture methods. Okay, all right. So that is the next method that you have, that is your culture methods. Okay, so you know about the traditional ones as well as the automated culture methods. That is your BACTEC 460 as well as your BACTEC MGIT 960. Okay, so these are the automated cultures. Now, after the automated cultures, the next investigation modality that you have, again very, very important, is the famous CB-NAT. Okay, CB-NAT, which is nothing but a cartridge based nucleic acid amplification test. Cartridge based nucleic acid amplification test, that is your CB-NAT. Okay, now this is one method which is very much endorsed by your WHO as well. Okay, the CB-NAT method. So this is based on nucleic acid amplification. You're trying to amplify the nucleic acid. So you can do this method from samples which are obtained from various sources. Like you can do with your sputum, you can do with your, say, a pleural fluid. In fact, you can do it with your CSF. The only thing is that you cannot do it with your urine and blood. You cannot do a gene expert, that is your CB-NAT, in your urine or blood. The instrument in which, I'll just show you the makeup of the instrument. So the instrument in which you do this is called a gene expert. Gene expert. So I told you this is a cartridge based nucleic acid amplification test. So for testing it, you require 2 ml. 2 ml of whatever specimen you are taking, that is put to this cartridge, and then you are actually trying to you see one more point I forgot to mention. This is also referred to as the CB-NAT MTB RIF method. Okay, MTB RIF method. So what is this MTB RIF method? Is that In addition to detecting your Mycobacterium tuberculosis, it will detect rifampicin resistance as well. Now see the importance of this test. When you are doing this particular test, not only are you detecting, if you see this part where you have the test result, you see, you can see whether you have detected the Mycobacterium tuberculosis, plus if the individual is having rifampicin resistance. You are not able to demonstrate resistance due to other drugs. Okay, other drug resistance you are not able to demonstrate, but rifampicin demonstrate resistance you are able to demonstrate. And one big advantage of this test is that this test hardly takes around 90 minutes, maybe 1.5 hour, 1 hour 45 minutes. That is the time that is taken to do this test. But some of the centers where the input of samples is too much, they might keep the specimen for doing it the next day, in which case you might get it the next day only. But always remember, it is not advised to store the sample and subsequently do this nucleic acid amplification test. It is always advised to do it then and there. You collect the sample and then get it to the laboratory and get it done immediately. That is when the yield also is increasing. So this is your CB-NAT test, a cartridge-based test, where you can see this cartridge is placed into the analyzer and subsequently it detects the presence of the organism as well as your resistance. So that is your CB-NAT. And this is just a screenshot that I have taken from a WHO website, where they have given the sensitivity of the various samples. Okay, when you do a CB-NAT, because CB-NAT is always now preferred. Okay, so because the yield is better, the sensitivity and specificity is also better. Because you see, in case of lymph node tissues or aspirates, suppose you are taking a lymph node aspirate and you are doing the CB-NAT, the sensitivity is almost 85%. In gastric fluid, again 84%, the other specimens around 81%. Pleural fluid, the sensitivity is slightly less, around 43%. So that is the only challenge, that is a pleural fluid. But other than that, all other specimens you have with above 80%. And when you do it in the sputum, when you do a sputum CB-NAT, it is almost 90%. Almost 90% sensitivity is there. So that is the advantage of CB-NAT over your sputum microscopy. Okay, you can very well do your sputum microscopy and CB-NAT, definitely. But I am just trying to tell you the advantage that a CB-NAT has over your mere microscopy. Now, there is an Indian version of this as well, of your Gene Expert CB-NAT, that is called your TrueNAT. Okay, that is the Indian version that was manufactured in India. So this again has been approved by the WHO. So TrueNAT also can be used for the making a diagnosis. Okay. Now after this, the cartridge-based nucleic acid amplification test, the next test is going to be a line probe assay. Line probe assay, which is called LPA. So this is again a PCR based technique where you are trying to amplify. So this is again a PCR based technique, just like your the Gene Expert. But this line probe assay has certain advantages. That is, it can detect, in addition to detecting tuberculosis, it can detect both INH and rifampicin resistance. Remember, for Gene Expert, your CB-NAT, you were detecting only the rifampicin resistance. Here you can demonstrate your INH and rifampicin resistance. And in a day, but sometimes it might take 48 hours, sometimes 72 hours. But in around a day or so, you might get the results of your line probe assay. So in this way, that since it detects both the resistance, it is having an advantage over your CB-NAT. And your line probe assay, your LPA, is again a favored investigation modality for tuberculosis. Now the problem with line probe assay, there is an issue with line probe assay, that you can do line probe assay only if the sputum smear is positive. Okay, only if the sputum smear is positive. Whereas in case of your CB-NAT, even if your sputum smear is negative, you should definitely go for your CB-NAT as well. So when you evaluate, if your sputum smear is negative, you should definitely do the CB-NAT, because sometimes something that is not detected in your sputum will be detected in your CB-NAT. But line probe assay is done only in sputum smear positive individuals. Okay. Now, other than the line probe assay, the fifth one is a urine LAM test. Okay, which is your urine lipoarabinomenin test. So that again has been tested for in the diagnosis of tuberculosis, especially those with HIV TB co-infection. The problem with this is that you can see that it is useful, but suboptimal sensitivity is an issue with your urine LAM test. So that is one problem with this test. Now, after urine LAM, the sixth one are the tests to detect TB infection. Okay, to detect a TB infection. So what are the tests to detect TB infection? I told you infection and disease is different. So when you go for detecting TB infection, you can either have the Manto test, that is your tuberculin skin test, or the TST. Also, you can have the interferon gamma release assays, which are based on the antigens, that is your ESAT6 and CFP10, based on that antigens. So there are two tests, interferon gamma release test. One is your quantiferon TB gold and other is your T-spot TB test. So these are the tests which predominantly detects an infection. Yes, it will detect a disease also, but the problem with these tests is that they cannot distinguish between a disease and an infection. So that is the problem. Just because somebody has got a positive tuberculin test or a Manto test doesn't mean that he is having the disease. And just because somebody has a interferon gamma release assay positive doesn't ensure that he is having a disease. Also, even if the test is negative, okay, if you have a Manto test negative, does it say that there is no chance for tuberculosis in this patient? No, because the tuberculin test that is based on what we will learn now is based on the immune response of the individual. So if it is an immunocompromised individual, maybe an individual with a retro infection, in such scenarios, what will happen is that he will not be able to mount a response and the test may be negative. Okay, so that is the issue with these tests. Okay, and let's see how this test is done. Manto test, a tuberculin skin test. So what you do is that you take 0.1 ml, which is 5 tuberculin units of PPD RT23, which is your PPD stands for purified protein derivative. So you are injecting it intradermally on the volar aspect of forearm, and then what you are looking for is that it's not the immediate response that you look. After around 48 to 72 hours, you will look for what? Please look at this. It is the width of induration. I want you to be very careful here, because I have seen some people, getting this wrong. It is not the erythema that is counted. It is the width of the induration that is being counted. So I'll just show you the picture, the correct method, and this is the correct method of doing this, and this is the incorrect method of reading this, not doing, reading. You see here, when you measure the results after 48 to 72 hours, you are just supposed to measure the induration. Because sometimes what can happen is that surrounding the induration, there may be erythema, but you are not required to measure the erythema. It is just the induration. See here, in this case, the person who is measuring the total, the diameter, including the erythema, that is not advised. So only the maximum width of the induration, that is the one should be measured. Okay, that is about your tuberculin skin test. So remember that even when you do a tuberculin skin test, a negative test doesn't mean that he is not having a tuberculous infection or a disease. Okay. Now, how do you read this? Induration above what is positive? See, that again is categorized. Okay. You are categorizing individuals for saying a positivity in your Manto test. See, in individuals who are not having any risk factors for TB, when the induration is more than or equal to 15 millimeter, that is 1.5 centimeter, you say that the tuberculin skin test is positive. Whereas for certain groups, when it goes above 10 millimeter, it is positive. What are they? Recent arrivals from high prevalence countries. So if you are coming from a region like India, where it is a high prevalence country, so above 10 millimeter, that is positive. IV drug abusers, and if that particular individual is residing where maybe in some colonies where you have lots of crowding, in such a scenario also above 10 is positive. If it is a mycobacteriology lab personnel, comorbid conditions like a chronic disease, like a chronic kidney disease, children less than 4 years of age, and infants, children and adolescents exposed to high risk categories. So if somebody is a high risk category for developing TB infection, in that scenario also it is above 10 is positive, because sometimes his relative, maybe his father might be a open case of tuberculosis. In such a case, above 10 millimeter is positive. So above 5 millimeter, when it is HIV positive and a recent contact, okay, not just any contact, a recent contact with an active TB patient. So if it is somebody who has had a, like if suppose if a person's father was a case of tuberculosis long back, and probably he's now staying somewhere else, this particular person is now staying somewhere else, then about 10 millimeter is the positivity. But if he is staying with someone maybe who's an active case of tuberculosis, then even more than 5 millimeter is positive. And nodular or fibrotic changes in the X-ray and organ transplant patients, in all these individuals above 5 millimeter is positive. So always remember the categorization of the tuberculin skin test to say a positivity. It's not the same for everyone. Now, other than this, you also have the other test, that is your interferon gamma release assays, the IGRA, in which you have the quantiferon TB Gold as well as the T-spot test. So the thing is that these are tests based on the serum sample. Probably, the only test in which you might have noticed in which your serum sample is being taken. Okay. So, and it is not that advised, because see what use it is going to give. It is likely to diagnose somebody with a latent tubercle bacilli infection. Correct. So in a scenario like in the Indian scenario, these tests are absolutely of no use. Then why these tests? These tests are useful in countries where the prevalence of TB is not that high. Because in that case, if you identify somebody who's having a latent tubercle bacillus infection, it is worth treating him, because already the prevalence is less. So you do not want this person, he might be having a latent tuberculous infection and he might have a reactivation later. So it is advised that you can treat this person. Okay, we'll come to the treatment aspect. What is the prophylaxis that we are giving? You can call it a prophylaxis. So we'll come to that later. But it is worth giving. But in a country like ours, where the tuberculous infection is very common, identifying someone with a latent tubercular infection, it's like, most of the persons who you would meet would be having some latent tubercle bacilli infection. So it is not worth doing all these tests in the Indian scenario. So that you should be careful of. So just a comparison of the tuberculin skin test as well as the interferon gamma relay assays. So see, for tuberculin skin test, you will have to wait for another 48 to 72 hours. Here you can do the test and obtain the result in 24 hours. There is one important point with respect to the TST, that is there is a booster phenomenon. That is, if you are repeating the tuberculin test to an individual, that is, suppose you have done a tuberculin test for the individual say 5 months back, and now you are again repeating, there is a chance that the induration might be more just because you are giving an additional dose of the PPD. Okay, so there is a chance of an augmented response, which you call it as the booster phenomenon. And one advantage that this interferon gamma release assay has is that it is not subjective. It is not subjective because, see, the other one is dependent on the reading by the healthcare provider, correct? The induration. So for me, it might be say around 4 millimeter. For you, you might say it is just above 5. So there can be slight variations. And BCG vaccination can cause a false positive TST. It does not cause any false positive IgRA. And again, whatever it be, a negative test does not rule out either a latent tuberculous infection or a tuberculous disease. So keep that in mind. Now, in addition to all these investigations that we have said, okay, the sixth one, the test for detecting latent tubercular infections, you can definitely go for a chest X-ray. You can definitely go for a CT thorax. But remember, CT thorax is just for a pulmonary tuberculosis. If you are suspecting a dissemination, it is always advised to go for a CT abdomen as well. And also, if you have a extra pulmonary suspicion, you can also go for your the CBNAT study from your pleural fluid or maybe from your CSF. Okay, in certain scenarios, even your pericardial fluid. You can even do it from your ascitic fluid. So, and also from your lymph node aspirate. I'll put that first, lymph node aspirate. So all these you can go for the extrapulmonary, because see, do not think that an individual will develop either pulmonary or extrapulmonary. He may develop a combination. He might have a pulmonary plus extrapulmonary tuberculosis. Okay, so certain scenarios you might have to do the extensive investigation based on the condition. Okay, so regarding the other extrapulmonary infections like a tubercular meningitis, we have discussed that in a separate module. Okay, so far these are the diagnostic modalities that you have for diagnosing tubercular infection. So let's now move to the treatment of tuberculosis. Treatment of tuberculosis. Again, a very, very important topic. Now this module on the treatment of tuberculosis will be centered around the NTEP, which is your National Tuberculosis Elimination Program. National Tuberculosis Elimination Program. Okay, so previously we had the RNTCP, Revised National Tuberculosis Control Program, but now the term RNTCP has been replaced. Now we just have the NTEP terminology. Okay, so the guidelines that we are going to follow for the treatment of tuberculosis is again your NTEP guidelines of 2020. Okay, so a lot of changes has happened in the guidelines compared to the RNTCP guidelines for the treatment. So I request everyone to be very attentive in this lecture, because remember, I started this chapter telling you that the treatment, the tuberculosis itself is a very, very important module. So you have got to know the treatment very well. So NTEP, let's have a look at the logo of NTEP. At least some of you would be familiar with the RNTCP logo, correct? So this one is slightly different. This is your NTEP logo. So see the slogan, TB harega, desh jeetega. So the details of the program, that is your NTEP program, would be covered in the PSM lectures. But what I want to focus here is from a clinical point of view, how the treatment has changed. Okay, and whatever a clinician should know from these guidelines, okay, on the treatment aspect. So let's move ahead with the guidelines. Now already I told you that in the previous module we had a discussion about the diagnostic modalities used in tuberculosis. We have already seen the utility of a sputum. It can be used for sputum smear. You can use the oil immersion microscopy. You can go for the fluorescence microscopy. Even you can have the LED microscopes as well. So that can be used. You can go for the cultures. So in the cultures, you have certain solid media like the Lowenstein-Jensen media, liquid media like the Middlebrook media. You have the automated culture methods. Then you have the molecular diagnostic test. We have seen the CB-NAT, the Indian version, the TrueNAT we have seen. And also we have seen regarding the line probe assay. So all these we have just seen, and these are the investigation modalities that are recommended in the NTP guidelines also in the diagnosis of tuberculosis. But let me also just make a mention of two other investigative modalities which are mentioned in the NTP guidelines. Though it is not that you are supposed to do this for like all patients, but they have just made a mention of this, so I'll just share it with you. One of the test, yes, is available now. The other test is not that available now, but it is. We hope that it might be available in the coming maybe few months itself. Okay, so let's see. The first one is the lateral flow urine lipoarabinomenin test. Okay, that is your LAM test, which is done in urine. So this test is done in usually in HIV positive patients in the urine who are having symptoms and signs of tuberculosis and a CD4 count that is less than 100. These are the patients in whom you can do a urine LAM. Then there is another test. This is the one I told you, which might come in the coming few months. So that is maybe probably the time you are seeing this lectures, maybe you might have actually this test might have actually come in place also, because the government is trying to push this test. Let's see when it actually would come into the diagnostics. So that is your CTB test. See, everyone has heard about the Manto test, your tuberculin skin test. This CTB test is again a very similar test, just like your tuberculin skin test. The only difference is that instead of the purified protein derivative, that is your PPD-RT23, instead of that, the antigen used in this intradermal skin test is the same antigens used in the interferon gamma release assays, that is your ISAT6 and CFP10. You can call this ISAT6, some say it is ESTA6 also, can be used both ways. So these two antigens are used, and again you are looking for the induration. So the CTB test, it is said that this test is better than the tuberculin test. It is not affected by the BCG vaccination status, and it is said that this test is likely to replace the tuberculin skin test. Okay, so just know these two tests as well, okay, in the diagnostics used in the NTP guidelines. Okay, all right. Now coming to the guidelines and the treatment proper. At least some of you would know the previous RNTCP guidelines where you had the various categories. Now, surprise, surprise, there is no category in your NTP guidelines. Okay, the NTP is not dividing it into any category 1, 2, 3, nothing like that. See, there are just two divisions. Okay, there are two divisions. One is whether it be pulmonary TB or extrapulmonary TB, just two divisions. One is your drug sensitive tuberculosis and other is your drug resistant tuberculosis. Okay, two divisions, drug sensitive and drug resistance. So why they have gone for this such a classification is probably because of the increasing drug resistance that is seen. Because when we began this module, we had a look at the stats. We saw how prevalent multi-drug resistance is, and you know that a major share of the world's drug-resistant tuberculosis again is coming from our country. So we have gone for a drug-sensitive and a drug-resistant TB division. Now, which again underlines the importance of testing for drug resistance. See, when you do the test, you have got to test for drug resistance as well. So how will you go for the drug resistance? See, you can go for the drug resistance by maybe when you're doing in a routine culture, and then you can go for a resistance testing. But the problem is certain culture media, the turnaround time is so much. You know that in Lowenstein-Jensen media, it can take up to 84 days. So even the liquid media also would take time around 42 days. But the advantage of the molecular diagnostic test is that, like a CBNAT, is that you can get the results in around 90 minutes. And you also have the line probe assay also, in which you get results relatively quickly. So maybe around 2 days, sometimes 3 days. Okay. So that is the advantage of the molecular diagnostic test in the evaluation of tuberculosis. So that will help us to ascertain drug resistance. So you have already learned so far that you have the CBNAT test, which will tell you not just that it will detect the Mycobacterium tuberculosis, it will also say if there is any rifampicin resistance. And similarly, you have the line probe assay, LPA. Now remember, in the previous module I have told you that this line probe assay will detect resistance to rifampicin as well as INH. But let me tell you one more point, that in line probe assay itself you have a first generation line probe assay and second generation line probe assay. So the first line probe assay, okay, or the first generation line probe assay, that will actually determine resistance to INH and rifampicin, whereas you have your second line probe assay. Okay, so second line is there, which will help us to determine the resistance to certain second line agents as well. Okay, so that was again endorsed by the WHO in 2016. So 2016 the WHO said, okay, you go for the second line probe assays as well, so that you can additionally determine if there are resistance to other agents as well. Okay, all right. So that is the importance of these diagnostic tests. So I hope you have understood the importance. Why I am talking about that is because you need to identify drug resistance. So just to show you the methods of drug susceptibility testing advised by the NTEP, you have the rapid test, which we have just discussed, which is the nucleic acid amplification test, your CBNAT, as well as the TrueNAT, which is the Indian version, and also your line probe assays as well. And you have the first line probe assay, where you can detect resistance to INH and rifampicin. Second line, which can detect resistance to levofloxacin, moxifloxacin, and the aminoglycosides, kanamycin, capreomycin, amikacin. But remember, all drug resistance, all the second line agent resistance cannot be determined by the second line probe assays, only these much. So certain drug resistance, even if it is some first line like a pyrazinamide, you will have to rely on other methods. So that is the growth based phenotypic drug susceptibility testing. That the first one, this one is actually called the genotypic test. So these rapid molecular diagnostic tests are called the genotypic test for drug susceptibility testing. And similarly, you have the phenotypic test as well. Phenotypic test. So in the phenotypic test, you have the various culture media. You can use the Lowenstein-Jensen. The problem is, the delay. You can use the Middlebrook method. So you can identify in such a method, you can identify resistance to most of the drugs. But the problem being the time it takes to give the result. So all in all, my message to begin with is to tell you the importance of going for tests to determine drug resistance. Now, if you ask me, sir, if I am in a facility where you don't have a CBNAT facility and a line probe assay facility nor a culture facility, then what? Can I not treat tuberculosis? Yes, you can. Because see, in our country, we are a resource limited country. So there will definitely be certain places where you don't have at present the facility for a CBNAT, though the government is trying to expand this, but you might not have facilities for doing all these tests. In such scenarios, you can go for a anti-tubercular therapy even without doing a culture or maybe a resistance testing. We'll come to that. how it is treated. But just know that as far as possible, do the drug sensitivity testing. And the government also in this guidelines makes a point like UDST, that is universal drug sensitivity testing, meaning that they are saying if possible for everyone do CBNAT, CBNAT, CBNAT. Okay, if possible for everyone do CBNAT, CBNAT, CBNAT. So you know that most of these specimens, whether it be a pulmonary tuberculosis or maybe a extra pulmonary tuberculosis, you can go for CBNAT. You can do it in your various specimens, maybe your sputum, your pleural fluid, or maybe your ascitic fluid. So you can, even your CSF, you can go for CBNAT. So it is again favored. Even the pleural biopsy is actually more favored than the pleural fluid, because there are problems with the pleural fluid. Okay, the yield is less. We have already seen in the previous module, but pleural biopsy would have a better yield. So you can go for all these specimens, but blood you usually do not go for, and also the urine is also not that favored. So for all these, you would go for the CBNAT testing. So go for the CBNAT testing, and if it is available, please do the first line line probe assay as well. That is what the government says. But UDST stands for CBNAT, and the government also says if there is facility, please do the first line probe assay also, and second line probe assay as and when needed also. Okay, so always keep that in mind. Now let's move to the treatment. We have already just said it is there is a drug sensitivity TB and drug resistant TB. So how are you going to deal with these entities? So when you treat drug sensitive tuberculosis, okay, suppose I'm going to treat a drug sensitive TB, okay, which means probably I've done a CBNAT and there is no INH resistance. And suppose you have done a first line probe assay also, there is no resistance to your like INH as well. So there is CBNAT showed there is no rifampicin resistance. The second test showed there is no INH resistance. So you have done the line probe and CBNAT, and now you are planning to treat the patient. Okay, there is no problem of any resistance. In such case, the total treatment duration is of 6 months. 6 months, where you have an intensive phase of 2 months and you have a continuation phase of 4 months. Okay. Now in the intensive phase, you will give HRZE, and in the continuation phase, you will give HRE. So what is this intensive phase, continuation phase? First of all, let me tell you these HRZE and HRE, the abbreviations. H is for INH, R is for rifampicin, Z for pyrazinamide, and E is for ethambutol. So when you treat tuberculosis in a drug sensitive individual, initially you will go for an intensive phase. Now what is this intensive phase means? Intensive phase is where you go for the kill, okay? You go aggressively so that you want to kill the bacteria, okay? That is the purpose of your intensive phase. And the purpose of the continuation phase is that there may be some bacteria that may persist. So to remove these persistent bacilli, you are going for the continuation phase, okay? That is just the logic behind an intensive phase and a continuation phase. So INH, rifampicin, pyrazinamide and ethambutol in the intensive phase, and in the continuation phase INH, rifampicin and ethambutol, no pyrazinamide. Okay, so that is going to be your 6th month regimen. Okay, now you see this is the regimen. Okay, so this applies to all new and previously treated cases. Only thing is that if it is drug sensitivity, even if you are developing tuberculosis maybe for the 2nd or 3rd time, the treatment actually remains same if you are drug sensitive. Okay, if you are drug sensitive. So this is 2 months HRSD plus 4 months HRE. Okay, now this applies to pulmonary tuberculosis or extrapulmonary tuberculosis. Remember, both would be, which is if drug sensitive, would fall in this umbrella of treatment, of intensive phase and continuation phase. Very clear, as simple as this. Now, what are the typical dosages used in case of adults? INH, this is again the treatment that is given, that the treatment that is given, it is going to be a daily dose, okay? Daily fixed dose regimen, okay? Based on the body weight, you are going for a fixed dose in this particular period, okay? Previously, like even in the previous RNTCP also they were saying about the daily dose, but I just want to tell you that it is not like you give once in say 3 days or so. It is given daily. That is the one that is currently followed. So daily fixed dose. And what is the dosing schedule? For INH it is 5 mg per kg, rifampicin 10, pyrazinamide 25, ethambutol 15 mg per kg. Now what about streptomycin? See, streptomycin, if you have seen here, there is no role in the drug sensitive tuberculosis. The role of streptomycin is only when either say many of the first line agent cannot be used because of some problem, maybe he has got some maybe resistance to that particular agent, or he's not tolerating that agent, whatever it is. Only in that scenario, and maybe some cases of tubercular meningitis as well, you might go for streptomycin. But mostly it is these first line agents that you will go for, okay? Very important. So you have understood the weight based dosing. Now it is also important to understand that once you go for a treatment, it is very important to ensure proper drug compliance. This is not a treatment where you start off and then send the patient home and say that, okay, come back after the 6-month period. No, you have got to periodically monitor the patient. You have got to test suppose if it is a sputum positive patient, you have got to test the sputum as well, whether he has turned negative. Otherwise, you might have to prolong the intensive phase, okay, if he is remaining sputum positive. Now, coming to the second part, that is your drug resistant tuberculosis. So drug sensitive tuberculosis, I hope, is very clear to you. Now we are moving to the drug resistant tuberculosis. Now, to understand a drug resistant TB, you have got to understand certain terminologies used in the guidelines. So they use certain terms like a monoresistance, a polyresistance, multi-drug resistance, rifampicin resistance, and extensive drug resistance. So these terminologies should be clear to you. Monoresistance means he is resistant to one first-line anti-TB drug. Okay, just one first-line anti-TB drug he is resistant, that is your monoresistance. Even if it is a rifampicin resistance, you can still call it a monoresistant. Okay, it is more resistant to one. If it is resistant to INH, it is just again a monoresistant. Polydrug resistance means other than INH and rifampicin, if the person is resistant to more than one first-line anti-tubercular drug, that is when you call it polydrug resistant. Okay, these are all very important because we are just going to see the treatment in a short while. Multi-drug resistance means the patient is resistant to INH and rifampicin. Okay, resistance to INH and rifampicin, which may or may not be associated with resistance to other first-line agents. Okay, so resistance to both INH and rifampicin with or without resistance to any of the other first-line agent. Rifampicin resistance means resistance to rifampicin. This terminology, extensive drug resistance, means it is nothing but an MDR TB case with an additional resistance to a fluoroquinolone as well as a second-line injectable like canomycin, amikacin, capreomycin. Okay, so MDR TB case additionally resistant to a fluoroquinolone and a second-line injectable TB. That is what you call a extensive drug resistance. So these terminologies should be clear. Now, the treatment of the drug resistant tuberculosis, you can again divide it. Okay, drug resistant TB from the treatment aspect. Okay, I'm saying from the treatment aspect, you can divide it because the treatment for these two categories are going to be same. One category is you have a resistance for either INH monoresistance, okay, that is resistance to only INH, or if you have a poly drug resistance, that is, these two belong to one category. Why to one category is because the treatment for these two would be the same. And then you have the second category where you have either the MDR tuberculosis, MDR TB, or your rifampicin resistance, Now for these two also the treatment would be the same. Okay. All right. Now let's see, how do we treat this one? How do we treat this one? That is what we are going to learn. Let's see it. Now this is one. Okay. So you have the regimen here. The first regimen that I have mentioned is the regimen for treating when there is a INH monoresistance or there is a poly drug resistance. Okay. The second and the third one, okay, these two, the second and the third one are for the MDR TB as well as for rifampicin resistance. First, let us see the first group, INH monoresistance or the polydrug resistance. See, in such a case, you do not have an intensive phase and continuation phase. Okay, there is no intensive phase and continuation phase. It is just 6 months of treatment. Okay, it is 6 months of treatment. And what are the agents that are used? Levofloxacin, rifampicin, pyrazinamide, ethambutol. Which means you just had, suppose you just had a INH resistance. You are actually replacing this INH with levofloxacin. Okay, so 6 months of levofloxacin, rifampicin, pyrazinamide and ethambutol. That is how you will treat INH resistance or polydrug resistance. Okay. Now, next is about the MDR as well as rifampicin resistance. For this, you have two type of treatment modalities. Okay. For this category, you have two type of treatment modalities. Either you can go for a shorter regimen or a longer regimen. Okay, a shorter regimen or a longer regimen. The shorter regimen again is divided into an intensive phase and continuation phase and has injectables also, whereas the longer regimen is just about oral agents and there is no intensive and continuation phase, just like the first one, that is your INH monoresistance treatment. It is just like you give the same drugs throughout the course. Okay. So for the shorter ones, you are going for an intensive phase of around 4 to 6 months with moxifloxacin. I'll tell you moxifloxacin. And if you see here, there is a superscript H written along with the moxifloxacin. Okay. So moxifloxacin, that means a high dose of moxifloxacin. Then you have kanamycin, moxifloxacin, kanamycin or amikacin, Then you have ethionamide, clofazimine, pyrazinamide, and then you have INH, and here also you will notice a superscript. So this is INH high dose. Similarly, you have moxifloxacin high dose and you have ethambutol. So with these agents, you will go for a intensive phase for around 4 to 6 months, and then you will go for a continuation phase where you will have a moxifloxacin, clofazimine, pyrazinamide, this E is not there, okay, pyrazinamide and ethambutol. So these are the agents for the continuation phase. Intensive phase, continuation phase. So total you will have around 9 to 11 months. Okay. Alright. So that is one regimen for the second category, that is your MDR TB as well as rifampicin resistance. But you can also go for a longer regimen. Longer means the duration is longer, for around 18 to 20 months. And the agents that are used in that longer regimen, remember the longer regimen does not have an intensive phase and continuation phase. The agents are, you can have your bedaquiline, levofloxacin, Then you have your linezolid, clofazimine, and cycloserine. Okay. So these are the agents, out of which the bedaquiline one you are giving it for 6 months, the first 6 months. The remaining you give for 18 to 20 months. Okay. So the third one means there is a 18 to 20 months you are giving the same drug regimen. Only thing is that bedaquiline is given for the first 6 months only. The rest of it is continued, and that will be the treatment. Now for these two, the shorter version as well as longer version, you can go for either of these. Okay. And the problem with the shorter version is that you have the injectables. So this is how you are dealing with your drug resistant tuberculosis. Okay, drug resistant tuberculosis. So you have got to know this. Okay, it is actually simple because they have simplified it into two groups. Only thing is that this should go in your head. The shorter regimen as well as the longer regimen and the agents that are used. But I'll tell you, this is something you should definitely know, because tuberculosis is such an important topic and you cannot miss anything from that. Okay, that is very important. So that is how you will deal with the drug resistant tuberculosis. And some cases, you might have to say, suppose you are going for the first drug, okay, the INH monoresistance, and if you find that the patient is remaining sputum positive, it is said that if after the 5th month of starting this regimen, that is the first one I am talking about, and the patient is persistently sputum positive, you might have to prolong the intensive phase. Okay, so in that case, the total duration may be extended to 9 months. Okay, so you need not know that much. Maybe at least this you should know, that how is the treatment being done in the drug resistant group. And here again, it is a daily dose that is given. Okay, so I hope this part that is very clear to you on the management of drug resistant tuberculosis. So I have tried to keep it very simple. For the drug sensitive, what is the treatment? 2 months HRSD plus 4 months HRE. Then you have the drug resistant group. In the drug resistant group, what are you dealing with? Is it a MDR-TP or rifampicin resistance? Then you will go for either the short term or the long term regimen. If it is an INH monoresistance, or maybe you have a resistance from other, like a polydrug resistance, then you will go for this regimen, a 6-month regimen of your levofloxacin, rifampicin, pyrazinamide and ethambutol. Okay. All right. So this is how you will deal with the treatment of tuberculosis.